So I know that people are just starting to log in, but we'll look at getting started. So welcome to the LSP London School of Paediatrics START Assessment Preparation Evening. So the plan for today is that we'll have a talk from a trainee about their experience of going through the START assessment. Then we'll have a talk from one of the TPDs about their side as an assessor. And then after both of those talks, we'll have an option for question and answer, and potentially, depending on parenting arrangements, someone might be able to be giving us a short talk on the experience from a trainee's perspective, but for the grid experience and the differences that you might have within that. So in terms of the other people helping with the session, so my name's George, I'm an ST6 in London and part of the education subcommittee. I'm joined by Caroline Reid, who's a respiratory paediatrics doctor and registrar, and she'll be talking about the trainee experience. And then we've got Jane Runnacles and Tushar Vince, who are both consultants and TPDs. And perhaps if they want to give themselves an introduction, if they're able to, and then Caroline, you can start sharing your slides.
Thanks, George. I'll just say a few words. Sorry, my name's Jane Runnacles. I'm a TPD for education. I'm sure you're all aware, but I would like to just signpost you to the fantastic YouTube resources that are up there already for the START talks. So these have been put together over years, and actually that's why we do a shorter evening tonight, because there are much longer talks on there which are worth looking at. So I'm sure George will say a bit more about that and about the forum later on. I'm very happy to take some questions later, but otherwise I will hand over to Tusha, who really is the expert. So thanks, Tusha.
Oh no, Caroline first.
Oh, apologies. Do you want to introduce yourself, Tusha?
Oh, okay, let me just come on. Hello, everyone. My name's Tushar Vince. I'm an intensivist down at King's, but I wear lots of different hats. So in terms of postgraduate land, I am the Vice Chair of START, and I am probably the one that's responsible for the feedback and standardization of the assessment. And I also do lots of other things, like I'm on the training quality board and whatever. And what we found is that if we ran our evenings like this, then the amount of anxious stuff that appears on social media like Twitter all disappears. I've even had a positive thumbs up on Twitter after one of these talks, because actually it I think debunks quite a lot of myths. So I'm hoping you're all going to get something out of this evening, and we thought that, well, I thought that actually if a trainee spoke first, like Caroline, then actually they can give you the introduction, and then I can answer all the nitty-gritty questions after my talk. So speak to you later.
Exam stands for Specialist Trainee Assessment of Readiness for Tenure, and this is my perspective on taking and preparing and taking for the exam. So just an outline of the stuff that I'm going to cover, a bit of kind of general information, mine and some other people who I've discussed with as approach to preparing for the assessment, a little bit about the stations, and then as we go through, a few resources that I used that I thought were quite helpful, and then kind of a bit of the practicalities of the actual like sitting of the assessment. I lifted this directly from the RCPCH website, just to try and reassure you, it's not an exam. You're not required to do any revision, but there is an element of kind of exam technique that is useful to show yourself at your kind of best. So although it's not an exam, there isn't a way to kind of approach it. So I found this statement reassuring, but also it doesn't mean you don't have to prepare for it. You want to show yourself at your best. So I would strongly suggest accessing the RCPCH website on the START assessment. They very helpfully, it's very transparent. It's all published, the kind of statements that you're marked against. You kind of think, well, if this is an exam, how am I going to be judged? It's very clearly set out, and you can access these published statements on the RCPCH website, and that really helps in terms of what you're aiming for. You get your feedback through your e-portfolio. I think it took about 6-8 weeks, something like that, after the assessment to get the feedback, and they've got the assessor feedback form there, so you'll be able to see kind of how your feedback will be given to you, but it's all through your e-portfolio. So a little bit about how to prepare. So I was fortunate enough when I took my START assessment that there was a fellow registrar working on the same job as me, who was also taking the assessment at the same time. So we were able to do a few kind of practice scenarios together and discuss what resources we were using. So that was very helpful. If you're thinking about kind of preparing in a group, there is a WhatsApp group for trainees taking the START examination. So that is, I know some people who've recently joined that and have found it helpful to kind of share resources and discuss kind of how they're doing their preparation. There's so many resources online. And I'd echo what Jane said about the START preparation video, particularly the one from the longest one from 2020, which has loads of information on each station, what to expect. So there's so much in that video. The LSP education group have also got a Padlet which has lots of resources and some scenarios, so that I also found quite helpful. Going back to kind of basics, and this is a recommendation from the RCPCH, is to read the GMC professional standards. It's actually quite a useful exercise. I actually found it it's not a difficult read, and there's lots of good information there, and very applicable to doing the START assessment. So those are just a few of the resources that and how I would approach preparation, and there's some other things that I will touch on as we go through. So in case you didn't know the format of the exam, there's 10 stations. Each one is 8 minutes, but you get 4 minutes between to read the scenario and prepare. There's 2 stations which are rest, but one of those is a kind of a preparation for the safe prescribing. So the safe prescribing station is a bit longer, so you get a bit longer to prepare for that one. Some scenarios are kind of a discussion back and forth. Some you do more of the talking. It feels a little bit like a marathon, but also a sprint when you're taking the exam, just because you feel the time pressure of each station, but there are 10 stations, so it's quite taxing, I would say, as all assessments are. But yeah, I will touch on this as we go through some of the stations. Try to use a structure. I've got a few examples, but find something that works for you. And if you're practicing, time yourself, because it's useful to know how long 8 minutes feels like for talking and discussion. So your 10 stations they're all scenario based, but some are more like clinical scenarios. You get you might get a handover station, something on logistics and organisation. There's lots of safeguarding incorporated. There's a station that is a critical review of a paper. And there's a safe prescribing station, something on ethics, consent and the law, conflict and risk management, and a station where you do some teaching. So I took this as my general approach to most of the stations. So thinking about the scenario in the short term, the medium term and the long term, you can also, I also did apply this to kind of looking first at the patient, widening to the family, talking about the team around the patient. So that is your kind of clinical team, and then the system, so the hospital around it. And I found that structure quite applicable to thinking about all the stations, so that I didn't panic or waffle and talk about nonsense, basically. So that was my kind of general approach, which I was able to apply to most of the stations. But if you haven't thought about that in advance, and had a practice about organizing your thoughts beforehand, then it probably wouldn't work. So I'm just going to go through some of the stations and how I thought about them and approached them. So for the handover station, this is something that you do quite a lot, but you probably don't think about it in the same way as kind of the station is set up. So you're given a handover sheet, and you basically have to discuss with the consultant who's there your approach to your kind of ward round or the day. So you get a list of patients, a brief clinical kind of scenario, and then you kind of go into your discussion. So I kind of used the approach that that you do anyway, but a bit more structured. So starting with like a safety huddle, thinking about staffing, equipment, external factors. You check with the consultant that you're discussing with who you've got available, and what their experience is and how confident or competent they are to kind of do what you hope that they would be able to. And then you can prioritize kind of the order that you see your patients and then allocate who will see. Think about if you're needing extra help, i.e. if you're thinking that you're not going to have enough people to see the patients, or there's an emergency, you can think about other kind of external things to draw on. So the nurse in charge, the site manager, if your scenario is set in a district general hospital, are there other people on the paediatric assessment unit or in ED that could come and help you? And the other thing that you kind of need to think of, because you're doing this as a day one consultant, is not just the clinical bit of the ward round, but how you're going to get these patients discharged or transferred out or wherever they're going to go. So that scenario, actually, that handover station was actually okay to do, because it is something that you do most days. So the literature review station, you get the paper 5 days before the assessment. So it's really good to be able to read it in advance. You can prepare notes and take them with you. So I used the Critical Appraisal of Skills programme. They've got a performer for every sort of study, and you can download and make notes reviewing your paper. So I did that, made notes, and you can take them with you and sit, and you've got the paper in front of you and the notes, and you can have the discussion with your consultant. You'll get a scenario with the paper, and you need to kind of apply it to the practice. So there will be a question. And my paper was about Optiflow and the use in bronchiolitis, and whether that was whether it shortened or lengthened the number of days of admission. And the question was about the scenario was about you're in a district general hospital. Should your hospital invest in more Optiflow machines? And it is a discussion, and there isn't a wrong or a right answer, but it's about applying the findings of the paper to your scenario. So that was my specific scenario. The prescribing station. So the format of this one for me was I was given a drug chart, and then the way that I approached it was going through the basics: name, age, weight, allergies, identifying any errors, any omissions, so was there anything missing from the chart, and then specific things to think about for this station were any kind of monitoring, so any drugs that needed monitoring, anything that like controlled drug prescriptions, particularly for outpatients, are written differently, so you need the address and written in full words rather than numbers, and then thinking about patient specific cases, so your neonates, any changes that need to be made if the patient is in renal failure, or if they're obese. So that's the kind of going through the drug chart, and then you thinking, kind of going back to the approach where you think about the patient, and then the family. If there's been an error on this drug chart, how would you approach that? And then if there has been an error, you will need to think about a duty of candor discussion, discussing with the family, and then if thinking wider, a system problem, do the staff need more training? How do you feed back to the person who's prescribed? So there's lots of things to think about. You think that this station is just about prescribing, but actually when you apply the looking at the first the patient, then the family, then the team, and then the system, there's lots of ways that the other kind of assessment of the START can be incorporated, so your other ethics and other bits and pieces, so it can all be put into every single station, and they're all quite real life scenarios, so all very plausible. So moving on to the teaching station. So my station was about teaching medical students about croup. So a lot, you've probably done a lot of teaching in your time of other colleagues, medical students. 8 minutes is not a long time, so you don't have very long, but you can use your basics of principles to teach, finding out about what the students know already, anything specific they want to learn, have some objectives you want to cover, but don't try and teach them about everything, and then make it interactive and asking questions, and then checking their understanding at the end. So it's a basic teaching form, but if you haven't thought about the structure before, you may you may try and teach too much, and then you won't have enough time to show how well they can understand. So safeguarding, this is something that you do all the time on your day-to-day jobs. Again, I took the approach of, if it was a scenario involving safeguarding, to focus on the child, then the family, other agencies, and then any kind of systems problems. But specifically with safeguarding, you kind of just need to think about other agencies that might be involved, so social care, police, schools, other GPs. So the kind of, when you do your level 3 safeguarding, this is, a lot of this is covered, and the other resources that other trainees have said they used was the child protection companion, but I find that's quite a comprehensive. If it's great to kind of look up little bits of the chapter, but it's quite lengthy. But just know about well, you probably do know about safeguarding, and there is a safeguarding element, I found, to most of the scenarios that I had. So the logistics and organisation. So this was the I felt that this was the most difficult thing to think about when I was preparing, because it's not something that I really knew about. You know about quality improvement, but writing a business case or kind of knowing about how the NHS is funded was something that I really didn't know very much about. I think a lot of this will probably change, but so far at the moment with NHS England, we don't know what's going to happen. But there's a useful video that's by the King's Fund on the NHS structure, which is useful to know, like, where the money comes from, because even as a consultant you're going to need at some point to fund a service, and that's useful to kind of know about. So there you may have a scenario on kind of the logistics and organisation, and that might be discussion about a quality improvement project or a business case. So this was the one that I was most apprehensive about, and I feel like I knew least about before I started preparing. I would say you don't need to know lots, but it's useful to know the basics about the NHS structure and how the day-to-day funding works. And if you're kind of thinking about ways to prepare without just doing lots of reading, getting involved with, or having just a discussion for 10 minutes of one of the managers is quite useful to know about kind of how they work and how they apply for funding for services and things like that. So that's what the advice that I would give for preparing for that station. So ethics, consent and the law. So where I would signpost you for this to have a kind of look at, there are so many resources available, and there's quite a few kind of well collated resources on the LSP Padlet, so that's quite a good place to look. With everybody knows the kind of the pillars of ethics, but I'm not sure that really helped. Well, it definitely didn't help me in my scenario. Actually, what is more useful is thinking about the practicalities of consent, and for my scenario it was a teenager who had mental health problems, who was refusing treatment. So that was kind of talking through that scenario. So it was kind of useful to know about assessing capacity, who can consent, and a little bit about the Mental Health Act. And actually I did actually really struggle with this station, and I think it was because I panicked and I really didn't use my structure, and I found it really hard, I'll be really honest. So that's my feedback on it, and I think it just, from kind of reflection on that, I think using like reading in advance was useful, but actually applying that knowledge was quite tricky. So I should have used a structure, basically. The other thing that comes into kind of ethics, consent and the law is kind of the process around when a child dies. So that's also quite useful to know about. So what I would suggest is find out wherever you work, find out find their guideline, find out what the process is of when a child dies, and that will stand you in good stead to kind of have a discussion about what would happen if a child dies, because it might be something that you've not encountered. So for kind of conflict scenarios, I practiced using the SPIES structure. So this is a well-known, people use it for consultant interviews. So seeking information about the situation, prioritizing patient safety, taking the initiative, which is kind of putting in place anything that you might want to do, escalating, so discussing with other colleagues, if it's for example, a trainee in difficulty, talking to the college tutor, and then discussing about support that needs to be put in place for either if it's a person in difficulty, them, if it's a department, members of the department, whilst the kind of conflict or the situation is being dealt with. So that's a very useful structure, and that's what I used. But yeah, there we've got some kind of possible scenarios that you might encounter. So a little bit about the practicalities for the exam. So it's online. You'll get the details via email before, and then plan the exam, the assessment day. So if you're going to take it at home, which you don't do it at work, do it at home. If you've got good Wi-Fi connection, fantastic. If you don't, you need to borrow a friend's house. If you have children at home, either kind of get them off to school, nursery, wherever, find grandma to look after them. If you've got builders next door, either remove yourself or remove them, but just make it's kind of, you want to show yourself at your best. And I would suggest, I did mine at home and it worked really well. It was really nice. It's nice to be in your own environment. You feel really comfortable, and yeah, just make the conditions optimal, because it's your assessment at the end of the day. Have your phone to hand. When I took the exam, they said if there was a problem, there was a number to call if you had a problem with the platform on the day. So just have that with you just in case, and have the number ready. I didn't have a problem, so it was all fine, but just so you know. They give you, on the email that you receive, there's a link just to test the platform the exam's on. So just to make sure that your camera works, the sound works, it loads on your computer. And I think you have to do it on either a laptop or a PC. So just bear that in mind. Have your water or your drink or your tea or whatever next to you, because as I said, it's like a marathon and a sprint at the same time, and you feel like you're doing a lot of talking, so it's useful to have a little drink, just to make sure that you don't get a dry mouth. You can have your notes, particularly have them for your literature appraisal, and you can take anything else and have them there. Have a pen and paper to make notes on the scenario, so that you kind of have a structure to what you're going to discuss because you've got those 4 minutes to read the scenario and prepare, so you can make some notes to jog your memory if you kind of need to, which I would suggest that you kind of do, so you've got time to do that, and then they're there in front of you if you kind of run out of things to say. So that's kind of or what I would say. I'd say I've put a slide for questions, but what I'll do is we'll probably have some time later on, so I won't take any questions now, but I'll let other people talk if that's okay. Or do you want to do questions?
That's great. Thanks, Caroline. I think we will probably leave overall questions. I'm happy for people to put their hands up if they've got anything now. There was one question that we had in the chat from Tom, which was, is there specific drug monitoring performer or guideline? Because he's highlighting the different trusts have different policies.
So there will be, each trust will have local guidelines, and if your trust doesn't, then you will use the BNF.
Yeah, so I think as long as you're following kind of a format, I don't think it would make a difference. I think that most trusts would have a reason why they would have it, and if it was within the realms of whatever trusts would use, even if there was slight variation, all of those would be seen as safe. Tushar,
I am here, don't worry.
Yeah.
No worries. Could I ask that Caroline has covered most things, which is great because you're getting it from, you know, a trainee and you can believe them. I know people don't tend to believe assessors. The one thing I will say is that Caroline called it an exam again and again and again. And the one thing she said at the beginning was, it is not an exam. Because let me ask you something. Look, she's even sitting there with her hand in front of her mouth now, bless her. Let me ask you to put your hands up. How many people do you think fail START? Put your hand up if you think it is possible to fail START. Because that's what an exam is. One person. Anyone want to keep Katie company, or is it that Katie, you had a question?
It's very noisy where I am. No, I thought you could fail it.
Absolutely not. You cannot fail START. Hence, it is not an exam. It is an assessment. Let me explain more. I hope you feel relieved by knowing that, by the way. Let me see. Let me share. PowerPoint. Right, I did save it. Let's have a look. No, that's not it. That's ridiculous. You don't want to see that from me. Manchester, that's what I've got it. I've given this talk around the country a fair few times. Manchester, there we go. Right, hopefully you can see my slides. I will take it back to the beginning. Don't worry. Slideshow from the beginning. Right, so START is START. Okay, that's what it stands for. What I want you to take away is, number one, why we have to do it. Number two, it really is not an exam, it's an assessment. And if we've got time, we'll go through some practice scenarios. But thankfully, because of Caroline, and great thanks to her, even though she was my registrar once upon a time, and even though she works at the same trust as me, I did not influence her talk whatsoever. And thankfully, because of her, I don't have to say very much. But the question is, why on earth do I have to do START? Especially if it's not an exam and I can't fail it and it costs a lot of money. The fact of the matter is the vast majority of colleges actually have a proper final exit exam. Can you imagine taking an exit exam and failing it, and therefore you can't become a consultant? And we don't think that that's very fair or very useful. But we do recognise that the step up that you took to middle grade was big. The step up that you take from training to consultant is even bigger. And it isn't the clinical stuff. It's all the non-technical stuff, the stuff you don't realise goes on. I don't know about you, but when I was a trainee, I thought that when I didn't see consultants on the shop floor, they were off playing golf somewhere. But the fact of the matter is, being clinical and on service is a relief from all the other non-technical nonsense that you have to do. So our assessment is based on the generic professional capabilities that you all have to do in your e-portfolio. And therefore, that is one of the reasons why you don't have to revise for START, because it is a day at work. That, however, doesn't mean that you can't prepare. And the reason I say that, and it's slightly different to what I said before, is START is probably more about the journey than it is about the result. By that, I mean the prep that you do for START can be slow and gentle. The answers that you provide in START are beautiful answers for your consultant interview. And so by that reason, preparing slowly and gently for START is not a bad idea. A question to you, I can't see your numbers at the moment. How many of you do CBDs? I hope all of you do CBDs. START is 10 CBDs, albeit in a row, but it is 10 CBDs. So if you like chatting like I do, it's great. Oh, can you not see the slides? Let me see. Did I stop? No, you couldn't. All right, let me try again. Thank you for raising it in the chat. Let me try again. Let me try again. Is that better?
Yeah, I can see that now.
Marvellous. I'm going to go back to the beginning so that you can make sure that I haven't missed anything. There you go. 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 Right. So the main reason the GMC brought in these GPCs is to bring standardisation across all the Royal Colleges, partly from patient safety inquiries. But of course, PEDS were the first college to be approved by the GMC, and that is otherwise known as Progress Plus. And you should recognise these names from your e-portfolio. So what do? We map it. So critical appraisal will be about research and scholarship, prescribing is about safety, etc., etc. Okay. Now I'll add a few things to what Caroline has said. So you all get the paper 5 days in advance. We are not looking to see how you appraise a paper in 4 minutes, which is why we give it to you in advance. We can tell the difference between people who understood the message and people who didn't understand the message, because people who understood the message relate the paper to the clinical question they've been asked. People who just carry on translating and interpreting the paper and not answering the question and not saying whether the paper was any good or not have not understood the task in hand. And that's what we're looking for. How do you apply the information in the paper to, number one, how valid and reliable is the paper? And number two, how applicable is it to your question? Safe prescribing is not about you prescribing anything. It is about how you manage and spot errors in prescription. Yeah. And the teaching bit and the duty of candor bit is also important. Teaching, we give you a clinical scenario and you can prepare any topic related to that clinical scenario. So Caroline talked about croup. So presumably the scenario was about an admission of a child with noisy breathing and a barking cough. Caroline could pick anything to do with croup. She could talk about the pathophysiology of croup. She could talk about why croup is a viral condition and you get upper airway obstruction from croup. She could have talked about how you differentiate croup from epiglottitis, how you treat it, how you look after it at home, what advice you would give, anything. But the key here is not your content. It is about how well you teach, the qualities of teaching. By that, I mean, it's not about what you teach, it's actually about what the people in your audience learn. So if you have got medical students, they are clearly different to an ST1. How will you change your teaching to pitch it accordingly? What will you do? How do you demonstrate that you reach a mixed audience of ST1 and medical students? So what you teach is less important. That means, therefore, if you've done a PhD on croup, please don't talk about that because you won't pitch it properly. Yeah, they are generalized topics that anybody should be able to teach on. So, for example, you could talk about APLS treatment of febrile convulsion if that's what your scenario is about. Conflict management, as Caroline said, people use spies. Again, I think the generic thing about START is look at every different party mentioned in the scenario and how is your management going to help them. So that means the patient, the family, any trainees, you as a team, your service. Handover. There are 2 handovers, but you only do one of them. If you are a neonatal trainee, a neonatal grid trainee, you will get a neonatal scenario. Everybody else gets a general pediatric scenario. And the reason for that is we are not looking for content. We are looking for how do you prioritize the sickest patient and how do you deploy your team. The ethics scenario is about all sorts of situations, but again, look at each party involved in the station instructions, in the scenario instructions. How has your management managed each of those people? And safeguarding, again, much like the ethics one. So everybody who takes START takes these 7 scenarios. If you are a general pediatric trainee, you will then take 3 scenarios that are case-based discussions, but they are in and around a general pediatric context. If you're a neonatal trainee, it will be around a neonatal context. If you're a grid trainee, it will be about your grid subspecialty. If you are a spin trainee, it will be the general pediatric one. Now, when we run our scenarios, there will be multiple people in the circuit. There might be a general pediatric trainee, neonatal, might be metabolic medicine, whatever. So when you enter that scenario, there will be a big pack and it will say on the front page, i.e. the opening landing page of your platform, if you're a general pediatrician, go to pages this. If you're a subspecialty, go to pages that. Make sure you go to the correct page for you. I know it's stressful, but please keep your wits about you. Medicine is stressful. You do a much more stressful job than most people and you manage work. So therefore, it should be okay to take a breath in and say, let me scan to see at which scenario I'm doing. Your assessor will check that you've read the correct scenario. And if you haven't, it doesn't matter. They'll work with you and take that into account. That's why it's okay that this is a formative assessment about the journey and not the destination. And therefore you can relax a bit more and really show us how you think and how you process. The vast majority of START is about your clinical decision making regarding clinical management and working with other folk. This then feeds into the overall assessment strategy. Your START assessment will be one of the things that ARCP panels look for. Not really about how you did, but what you did about your START scenario, i.e. your START PDP. So we will give you feedback. We tell you what the scenario was about. We tell you where you are during the professional conversation. And we try to give you tips about how to get there. which that's the bit that leads to your PDP. Now, I've heard that there have been some complaints that, oh, this is very generic, it's not very specific. But considering where we were, where some people got nothing more than good job, well done, which wasn't very useful, at least now you know where you need to be and where you are at the time of the assessment. So even if these bits of how to get there don't feel very helpful, you can use your common sense and your conversation with your ES to produce a really good quality PDP. And that is what your ARCP panel will be looking for. And remember, this is likely to come up at your final ARCP, the one where you're CCTing. So you really need to be focusing on this. So START is not an exit exam. It's nothing like this. It is about who you are at the time of the assessment and what you need to focus on. Since 2012, I think there have been 3 trainees who had a really bad start, so bad that people were worried about the performance. However, that aligned with what the educational supervisors thought. So no trainee has been prevented from getting a CCT on the basis of START alone. So again, this is about the journey. One cannot fail START, and it is not an exam. So what does it feel like for you on the day? You only do half a day. The assessment, however, lasts probably 2 or 3 days. And on each day, we have 2, maybe 3 simultaneous circuits, and we are looking at all trainees at the same time. And there are 2 sessions a day. So maximum, we could have 6 sessions a day, and we could have 3 days. So that's 18 sessions. Each diet will have 10 scenarios and a rest station. So therefore that's 11 times 18. That's about 200 trainees at any one time. Yeah, we shortlist according to your CCT date. And I know that there have been some issues with people saying, oh, I want to fast track, and so therefore I need to sit my start earlier. We can't manage that in START because we need to have a, if you like, a testimonial from your TPD or your head of school to say, yes, this person is likely to CCT early. So because that takes a lot of chasing and it delays everything, what college have decided is that we will go on your CCT as per your last ARCP date. So it is a catch-22 for people who want to fast track, and it is not something that college can cope with and manage. Okay, so therefore we will at college go with your CCT date as per your last ARCP. How do you approach START? You come to work. It's definite that you have to come to work. You have to experience things. You have to talk about it with other people. That is how you have learned different things. It's by coming to work and talking. You've done case-based scenarios. So why not try practicing? Caroline said do it under timed conditions. That's a great idea. How about doing 2 to 3 case-based discussions in a row so that you get very little downtime between them, very little time to catch your breath. I will repeat that you need to read the scenario. The message is don't tell me what you want to do, tell me what you would do. Yeah, and be specific in your answers by providing examples of what you would ask. You know, if you were, it's like people saying, why do you think that this is a safeguarding issue? Well, the history is inconsistent. The history varies from people. The physical findings do not match the history. Those are specifics rather than, well, the story doesn't seem quite right. In terms of preparation, I've given you a rough idea, and Caroline has made a great inroad into this. If you were going to read anything just for background and to make you feel better, really, you could read some nice guidelines. You don't have to read recent guidelines or changes at all, because remember, these scenarios were written about a year in advance at least. Reading GMC guidance on confidentiality, consent, capacity, duty of care, all of these things are really, really important. Caroline is also right about the ethics thing. Those 4 pillars are really passé now. And you should see that when people are discussing things like end-of-life care, ethical situations at work, they're not talking about that. They're talking about best interests. So read up about that. No one, absolutely no one is going to be talking to you about the recent Supreme Court finding or case law that says that we will lose our anonymity if we're involved in difficult end-of-life cases. So don't even think about reading that. So you'll start with different schedules. That is really about people with reasonable adjustments. So if you have any type of reasonable adjustment, let college know. Obviously, you'll need objective independent evidence. But for example, if you suffer with mood-related disorders and you prefer to have your exam in the afternoon, your assessment in the afternoon, let us know and college can move things around. If you are breastfeeding, that's absolutely fine. I have seen trainees kind of hand off their baby to somebody else just as they start a scenario. It is not an issue whatsoever. Do what makes you feel good. However, I would say that whilst this is a virtual assessment, very few people are in work mode if they're in their pajamas and if they're in home clothes like lounge wear or whatever. I would suggest you dress up as you would do for work, whether that's scrubs, I wouldn't recommend it, or whether that is, you know, some kind of work clothes. I would do that because it puts your mind in the right mindset and the right frame in order to do this set of 10 professional conversations with a colleague. Imagine that you're giving advice to somebody else. You know, you look a bit more professional, you'll act a bit more professional if you're in your work clothes. It is a long haul. There is a break in the middle of it. So it's well worth bearing in mind, as Caroline said, get rid of everybody in the house so you've got your Wi-Fi to yourself. Please, please, please test it with OSLA beforehand, and do it, if you like, at the same time that you will be taking your assessment, maybe a few days before. That way you can replicate your Wi-Fi needs and your bandwidth needs. Each assessor will have access to your individual mobile phone number. So if the Wi-Fi fails completely, we can potentially still run the assessment over the telephone with you if, for example, your audio doesn't work on your laptop. It is a good idea, if you can, to run the assessment on a desktop computer. 2 screens is better than 1 screen. 1 screen is better than laptop. Laptop is better than an iPad, and phone just won't work. You will be able to zoom in and out of the screen so you can read your instructions and take notes as you need to. We don't mind if you take notes, but clearly if you're reading off something else, that will be noted in your feedback because it affects your ability to demonstrate your ability to think on your feet. And that's what we're looking for, because that's what we as consultants have to do time and time again. Sometimes we're able to plan it and therefore we get 4 minutes to do it. We are walking towards an angry parent and we are working out how we're going to have that conversation with them. And that's what this is trying to replicate. So if you're reading all of your answers on off a screen, it's going to be raised because you're not having a professional conversation. What you're doing is having a professional monologue. So I guess the other thing about the START assessment is that this is a conversation. Trainees get really upset on a number of issues. What they'll say is that I want to get everything out. I want to say everything. We're not interested in everything. We're interested in understanding how you have picked the most important things to discuss. Now, that might be based on clinical priority. That might be on the most powerful argument that you're going to present. And if you monologue at us, we can't help you, because you're not having a conversation. You're showing us how you can talk over us and not allow us to contribute to the conversation. If we try and intervene, that's us trying to steer you towards getting a better score. So then if you complain about us intervening, because perhaps it has affected your flow of conversation, who wins? Because I'm really hoping you don't, in clinical practice, just talk and talk and talk and talk and talk and don't let anybody else speak. Surely it's part of our professionalism to allow other folk to speak. So on the day you will get a briefing. They'll tell you this is a series of 10 CBDs and when you will get your result. The standard we're looking for is, are you at the standard of a day one consultant? That is meeting expectations. Now remember, you're going to be 12 to 18 months prior to that. So you shouldn't expect to be here. You should expect to be here at the good trainee standard. Most of you will get quite a few of these. Great. But if you get lots of these, you've still got to get to that point. Some of you will get some of these. In a bell-shaped curve, we should be expecting lots between here. Significant concerns is about when we say a trainee is not quite even a senior trainee. So maybe the educational supervisor needs to intervene here. And what we're interested in is what you need to do to move you up each spot. So when you're creating your PDP, if you have any significant concerns, they have to be addressed and completed before your CCT. So therefore it has to be in the ARCP after you've created your PDP. If you get a run of themes in needs further development, address that theme. We will notify your educational supervisor if you get any significant concerns or over 3 needs further development, because this is not a question of hiding, because this should not be shameful. This should not be something you are unhappy with. This should be a trigger to say, that's what I need to work on. So therefore, to help that, to make it open and transparent, we notify your educational supervisor, and you should therefore have a conversation with them about how to create your PDP. You're going to get 10 bits of feedback. So pick out the 2 or 3 points that will really cover the majority of the assessment or give you the biggest success for minimal effort. If you've got none of these, you're really lucky and you're going to be across here. Same principle applies. Pick 2 or 3 that's really going to help you feel more confident when you become a consultant. And put that into practice in your final year by doing leader CBDs, attending governance meetings, etc. And from that, I have no further slides. Are there any questions? I'm going to stop sharing for a bit.
Thanks, Trisha. So I don't know if you have been able to
I didn't
see in the chat, which is fine. So I'll start with the first one that hasn't been fully answered, and you did talk about it a little bit, which is about how common are neonatal scenarios in the general START, that is to say for non-neonatal GRID people, so managing preterms or antenatal counselling.
It won't be like that. It won't be specific to neonatal stuff. It will be more things that you can extrapolate from a neonatal thing. So, you know, for example, because you will have all done, you know, a fair bit of time in neonates, you might have, let me see, a prescribing scenario of neonatal meningitis. How might you manage that? And if you have a, let's say, if you have a prescription sheet that gives you a dose of acyclovir of, you know, 500 milligrams per meter squared, that is clearly incorrect for a prem. So it's things that you will be able to extrapolate from. If you are in the other ones, it doesn't really count as a neonatal one at all.
And there's a question that says this list, and I'm not sure exactly which one, didn't include logistics and risk management. It may have been an example.
That's conflict. That comes under conflict.
Wasn't a fully sort of, what may not have been given all of the details of everything. I'm not sure. Anyway.
Yeah, but it comes under conflict because actually every time you do a business scenario, a new business case, it's about gathering evidence, patience, negotiation, which is what you do with conflict. You have patience, you have negotiation. So it all comes under conflict and risk management.
And there's another question which Jane had answered in the chat. There's a question from Dom, who's asking about essentially the logistics of organising different dates. His assessment date is between two sets of night shifts, and he says that he's spoken with his rota coordinators and they're not able to help with a swap. And he's asking what is expected in this scenario, which is a bit challenging in this setting. But I don't know if you've got an answer for that, or if that might be something that he needs to speak directly with the college.
I think you need to take up your educational supervisor, actually, because
that's what I would do.
Yeah,
I would actually escalate it from the ES to the CT as well. This is a mandated assessment, and yes, it's formative, but you do want to demonstrate your best, don't you? I have to say, I am really weird. I actually perform better after nights, and every successful interview I have ever had, I have done straight from a night shift. But I'm weird. I think it's because I'm quite garrulous, and therefore I'm not so garrulous when I'm tired. Absolutely, I think that this should go to your ES and your CT for them to shout at the rota coordinator. I suspect your rota coordinator is a professional services member of staff rather than a clinician. If they are a clinician, as an Indian mother, I would beat them around the head with my slipper.
So maybe to speak with the educational supervisor.
Yeah. And actually, if you are at Guy's and St Thomas's, I would suggest getting Chloe Macaulay on your side, because she will fight the battle for you.
There's Emma, who is also someone who's potentially going to give a experience from GRID. Emma, you mentioned there about having had a neonatal safeguarding case. Just going back to the thing about I think I'm not sure if there's anything further to add, but I think it was basically to add that while there may be themes that include neonates, it doesn't necessarily need tertiary level neonatal. It's not very specific for neonates. And I think
so. I'm hoping. Sorry, George, to talk over you. No, I'm hoping what Emma's trying to say there is you can extrapolate from the neonatal situation and make it into a pediatric one. I mean, we know that infants have a lot of issues and they probably have more safeguarding situations in terms of physical abuse than the older child, who will have more psychological and neglect issues.
Yeah, exactly.
Yeah. Tom had said something about the safe prescribing, what kind of guidelines. Just stick with the BNF. The treatment guidelines in the BNF will hold you in good stead. You don't need anything more than that.
If it's any help, I was actually given in my scenario the kind of information that I needed. I actually didn't need to look up anything specific. I did double check that the information, if I'm honest, that was given to me was correct, but it was given to me.
And that will be because the BNF contained too much information and we wanted to focus you on a particular part of that. So if you get something that you're not expecting, it is there to help you. If you get nothing extra, it's because what you have is good enough.
Brilliant, thank you.
No worries. Keep the questions coming in whilst you hear from other folk.
While we're waiting, Emma, had you either any, I'm not sure if you'd necessarily prepared slides, but do you have anything specific that you wanted to say about the differences that, you know, from the grid presentation, or is it more if there's, it depends, I guess, a little bit whether there's anyone on the call who has specific questions about the assessment if you're doing it from a grid perspective.
Yeah, happy to answer questions. I do respiratory. I'm being completely honest, I haven't actually got my results, so I don't know what they're going to be like. But from a kind of logistics perspective of a grid trainee, it's very obvious which scenarios are related. And it very much tells you at the top of the page, if you are respiratory, use scenario 4. And so you scroll down and then it says at the top, plastered over at respiratory. So I was like, okay, fine. This is obviously my scenario. And it was a typical scenario that we see all the time in grid respiratory. So like I had a CF case, I had a severe asthma case, if that's any help. But it's you can't really go wrong, I would say. I mean, there was an allergy one before me and it was very allergy and I had no idea, so I was
could I add to that? You'll notice that both Caroline and Emma have told you what has come up. That is obviously not what would happen with the summative assessment, and I'd be sitting there going, shh, don't say it, don't say it. The fact of the matter is that just because they've had an asthma one or a CF one, you'd be crazy if you're respiratory to think that you'd get through an assessment without discussing CF and asthma. But it's not the clinical stuff that we're looking for. It is stuff like, you know, you've got a patient who is non-compliant with asthma or with CF. You've got a patient who is deteriorating. How are you going to manage it? You've got a patient who is being looked after at the DGH and keeps being admitted there. How are you going to look after it? So it's those kind of generic things we're talking about, rather than that, how would you treat serratia or Pseudomonas? Is that fair, the two respiratory ladies?
100%. It was a stuff that I have done lots and lots of times and very much in keeping with daily work. It wasn't anything niche, and I didn't feel that it was an unfair assessment of my respiratory grid perspective, if that's any help.
I would also say that is why people can get away with doing the wrong scenario, because it's all very generic. Yeah, you can imagine I'm not a respiratory person. I could have answered those questions. Yeah, about how you deal with a non-compliant teenager, etc., etc. So nobody who has come to an LSP talk or nationwide has come out of this talk and given me feedback that I feel worse about the assessment. Not one person I have met has come out of START and said, well, that was flipping awful. The vast majority of people have come out and said, actually, it made me think about what I don't know and what I would like to know more about before I become a consultant. And that is the purpose of the whole adventure. So please use it and think of it as training and a side quest whilst you reach your, final quest of CCT.
Okay, and then one specific more for the admin and WhatsApp side of things. And Bush has just asked about the WhatsApp group. So I think for the first link that I posted, that's a more generic group, which may be more helpful if you're not doing the assessment this time round. Whereas I think that the link for the July START assessment may be more specifically for people that are actively doing preparation. But at the same time, I think that link is on there. Someone's posted it, and I think it's fairly open for people to join that group. So I'm sure that there wouldn't be an issue with you joining and having a look and seeing what people are discussing on there, if that's helpful.
What I would say from my perspective is that, yes, I joined the really big group, and then I joined the group that was associated with I did it in April with April START. From that, I definitely formed a splinter group where it was 4 of us doing scenarios at each other rather than as part of the big group. And the big group was wonderful for, if you like, talks and information and things that I needed to read and things that I kind of possibly hadn't thought about. But for actual practice, I definitely formed a small group, and it was very much backwards and forwards doing 8-minute scenarios and, oh, have you thought of this? Or what about this? Yeah.
Sure. Thanks, Sarah. Okay. Does anyone on the call have any further questions? Either can pop their hands up or put it in the chat. If not, then hopefully send details around at the beginning for both the WhatsApp groups, and you can contact us if you have any further questions. Unless anyone else from the group has anything further that they would like to add or say, other than repeating that it's not an exam, you can't fail, and you'll all enjoy it. Then I would close by saying thank you very much to Tisha, Emma, Jane, and especially Caroline for her presentation at the beginning. And thank you all for listening, and hope it was useful. And if you do get a feedback survey later on, or want to give us any direct feedback on how we can improve it, that would be really useful. Otherwise, thanks everyone, and I'll close and finish the talk now. Thank you. Bye.
And thank you, George, for
thank you, George.
So appreciated, George, and thanks to all our speakers, and thanks, Caroline, as well. So if any of you take START and want to come back and talk with us, then do get in touch. Good luck, everybody.
Bye.
Bye.
Bye.